I'm glad to be here. I think originally the impression was that I would come to talk regarding meaningful use in ARA, and I understand that you may also want me to talk about the Affordable Care Act, which is the act that affects patients. So I will go over ARA and meaningful use, and if time permits, I will talk a little bit about the Affordable Care Act and the two biggest factors that is affecting patients today, okay? So what exactly is ARA? As I travel nationwide as well as internationally, a lot of people are confused because they believe that ARA is healthcare reform. What ARA actually is the American Recovery and Reinvestment Act, 2009. And this is actually the stimulus package that the Obama administration and Congress approved to help with the financial crisis that was going on at the time. And so there were some specific targets that ARA needed to accomplish. One was to create new jobs, because at the time our unemployment rate was above 8%. The second was to spur economic activity because our markets were down pretty severely. The third, and this is sort of one of the battles that is going on today in the US, is to foster unprecedented levels of accountability and transparency in government spending. And if you've been following the US, you've probably heard of all the financial battles about spending and revenue that's been going on. Some of the other things, and I should say, the way that Congress structured this was through tax cuts, funding for entitlement programs, and the entitlement programs is pretty sticky, because when we talk about meaningful use, we're going to be talking about the two government-ran insurance medical plans, and funding for contractors, grants and loans. And grants and loans will include student loans, as well as what we call Pell Grants, which are student grants for higher education. So ARA is the umbrella. Under ARA, we have what's called the HITECH Act of 2009, and that is the Health Information Technology, Economic, and Clinical Health Act. This is actually the act under which meaningful use and certification for vendors come under. And Affordable Care Act is, of course, the other act under ARA, and that affects patients. So beginning in 2011, the government will provide financial incentives for organizations, healthcare organizations, to adopt electronic health record. And that is really one of the main purposes of the HITECH Act, was to spur the adoption of electronic health record. Now, some may not know, but the US actually began this adoption program in 2004 under President Bush's administration, but the adoption rate was very minimal. And so by providing funding, the ideal was that it may spur EHR adoption. Healthcare organizations, providers, under meaningful use is really demonstrating meaningful use of electronic health record. There is a sub-target with that, and we may touch upon that later on. But the main purpose was that healthcare providers demonstrate meaningful use of electronic health records. Funding would also encourage a health IT infrastructure. Unlike many countries that have state-run or national infrastructures, the US is a private market, and so we don't have a continuous nationwide health IT infrastructure. And so the HITECH Act would provide funding to stimulate and help create an IT infrastructure. And the Centers of Medicaid and Medicare Services, which is the agency that oversees and runs the two federally funded insurance medical programs, Medicare and Medicaid, are the overseers of meaningful use. So there's 3 stages. There's rumor of a 4th and possibly 5th stage, but we'll leave that in the rumor mill. But 3 stages of meaningful use will be implemented, and healthcare providers and organizations must demonstrate meaningful use of these 3 stages over a period of 5 years. And so what that means is, 1, they must start at stage 1. And from stage 1 to stage 2 and to stage 3, over a 5-year period, they will be provided financial incentives if they can demonstrate meaningful use of electronic health record. Now, the HITECH Act defines providers. We define providers as eligible providers, eligible hospitals, and critical access hospitals. So throughout the presentation, you will see EP, EH, and CAH, and those represent those providers. Eligible providers, in this sense, is equivalent to your ambulatory setting providers, your primary physicians, your clinics. Eligible hospitals, of course, are hospitals. And critical access hospitals, they are special healthcare organizations. They are hospitals. But they are hospitals that are located in what we call rural areas. They are defined specifically by Medicare, and so their payment structure and incentives is based upon how Medicare has defined what a critical access hospital is. And just to give you an example of a CHH, a mountainous area where you have a small town, rural town, and you may be 50 miles to 100 miles outside of a city, and you may have a hospital or a small healthcare or facility that serves that particular rural town. And that rural facility has to be a certain amount of miles outside of a major city or a city. And it has to be within a certain amount of miles within the town that it serves. And that's just a simple definition of what a critical access hospital is. It's open 24/7. It does provide limited healthcare services, but it does provide services for the community, and as long as it meets the Medicare definition, it is eligible under the HITECH Act for financial incentives, as well as implementing and adopting EHR. So we are currently in stage 1, with stage 2 beginning October of this year. So this table I have gives you, hopefully, an idea of the payment structure, as I talked about, of the 3 stages over 5 years for healthcare organizations. So beginning with 2011, hospitals had the option to begin adopting EHR, as well as demonstrating meaningful use of the EHR. And they would be provided incentives their first 2 years of stage 1. Now, if they started in 2011, then they get an extra year because stage 2 doesn't start to 2014. And for us, the fiscal year 2014 begins October 1st, 2013. 2 years at stage 2, and then you would be required to go to stage 3. Now, as the table dictates, after 2014 or out of 2014, organizations that has not begun demonstrating meaningful use will see a payment adjustment in their reimbursements. So the push was to get organizations to begin adopting EHR and demonstrating meaningful use 2011. But at the 2014 year, they are now required. And if they don't at that point, and going forward, as you see in the years, stage 1, the financial incentive decreases each year after 2014. So there are 3 components to meaningful use. And one important note about meaningful use is, again, we're talking only about providers and healthcare organizations. We are not yet talking about the technology that needs to be in place to demonstrate meaningful use. So use of a certified EHR, and in certified EHR we're talking technology, in a meaningful use manner. The use of a certified EHR technology for electronic exchange of health information, and the use of certified technology to submit what we call clinical quality measures. Those are the 3 components of meaningful use. So to demonstrate meaningful use of the EHR, to be able to effectively exchange health information, and clinical quality measures. Now, clinical quality measure gets a little bit sticky, so I'll try my best to give a simple definition of actually what they are be used for. But first, let's talk about the outcomes. Improve quality, safety, efficiency, and reduce health diagnosis. More patient engagement, improvement in the reporting of population and public health, and last but not least, maintaining privacy and the security of patients' data. These are the outcomes that were set out for meaningful use. And one thing to note, although I didn't mention the improvement of care coordination, all of them together improves care coordination. This also spurs a new trend, which is called community health, where we will have organizations, community of organizations, your hospital, your clinic, your pharmacy, your specialties, all exchanging health information in coordination of the treatment of the patient. So these outcomes and the measures that I will show you in a few minutes all point to providing a higher standard of quality of treatment for the patient, as well as spurring a continuous community effort of providers to provide the population quality treatment. So, eligible providers, as I stated before, really your ambulatory setting, your primary care physicians, your clinics, they have some objectives to meet to successfully demonstrate meaningful use. They have to pass 15 core objectives, and core objectives are required objectives. 5 objectives out of the 10 from a menu set. Look at the menu set as optional objectives. They do not have to do all 10, but they do have to do 5 of the 10, okay? 6 total clinical quality measures. Now, I will try to give you a simple definition of clinical quality measure. Clinical quality measures are the measures that an organization pulls from the EHR, converts to a report, and submits to the government as evidence of meaningful use. Okay? And so when I talk about the measures, just think of the measures and the data that's associated with those measures being calculated into a report, and that report then goes to CMS, and then CMS will use that data for purposes of reporting and figuring out if meaningful use is actually working, if we're seeing a higher quality of treatment for patients. So this is the EPs. The hospitals are a bit different because of the type of setting. So the hospitals must successfully demonstrate 14 core objectives, 5 objectives out of the 10 menu sets, but they have to demonstrate or successfully pass 15 clinical quality measures, which will make sense because in an acute setting, you would have a more targeted, specialized treatment for the patient. So let's look at stage 1. And I use this table because I want to hopefully help you all relate the measures to the outcome. So we have the health outcomes policy priority, improving quality, safety, efficiency, and reducing health disparities. Now we have some stage 1 objectives, and then we have meaningful use measures, okay? So we look at the first one. We are trying to target getting physicians to do electronic ordering. And in stage 1, they have to meet a 30% threshold of unique patients with at least one patient in their medication list seen by the EP or admitted to the hospital and have at least one medication order entered into the EHR using electronic physician order entry. And as we go down these, pay attention to the threshold, the percentage, because as the stages go up, each stage builds upon the previous stage. So I'm going to show you a slide that compares stage 1 to stage 2, and you'll see some dramatic differences in the thresholds and what providers would have to meet in order to successfully demonstrate meaningful use. But as you also see in this table, we are expecting providers to really provide a lot of detailed data and make sure that data is available in the electronic health record. And this is a workflow change for a lot of providers, as well as nursing, because not all of this will be inputted by the physician, but the physician ultimately is responsible to make sure that they are successfully demonstrating meaningful use. And as you can imagine, as stage 1 was coming to fruition, you had a lot of physicians that were really making a case known of why they need to do this, because it is, for a lot of physicians, a change in how they provide treatment. So again, these tables is just to give you an idea of the objective and as it relates to the outcome that we need to achieve. So stage 1, again, began in 2011. It's now 2013, and as we looked at on the payment table, stage 1 goes out beyond. And it will be the same for stage 2 and stage 3. But stage 2 builds upon stage 1. So once you are able to successfully demonstrate meaningful use, stage 2 then encourages more use of EHR in providing treatment. So for stage 2, all providers, regardless of their stage of meaningful use, are only required to demonstrate meaningful use for a 3-month reporting period. Now, we talked about clinical quality measures, and I talked about the reports that are generated and calculated and sent out to the government. So in stage 1, once you have attested and demonstrated meaningful use, you can submit reporting for 1 full year. In stage 2, your first year is only a 3-month reporting period. So providers would only have to provide data that they are meaningfully using EHR for 3 months for 2014. After 2014, after their first year, then it is a full year of reporting that must be submitted. So the objectives. First stage, the objectives are low. Now we see an increase in the core objectives that must be met. So stage 2, eligible providers will have to demonstrate 17 core objectives. 3 menu objectives that they select from a total of 6, or a total of 20 objectives. Now, while I'm only providing you the objectives, I'll give you a note of actually the number of some of the objectives. For example, the clinical quality measures for stage 1 was up around 51. So, in stage 2 is actually 64. So, still, they have to demonstrate not many of the objectives. Stage 1, I believe we had close to 100 objectives, including the menu set. Stage 2, I believe, is around 110. And I'm not sure about that number, but I believe it's around that time. So there's a lot of objectives, there's a lot of measures, but again, at this point, they only have to demonstrate a small percentage of those objectives and those measures. The eligible hospitals and the CAHs, 16 core objectives, 3 menu objectives of the 6, or a total of 19 core objectives. Now, this is a dramatic change from stage 1. Stage 1, you had distinctive menu sets. What happens is in stage 2, those menu objectives from stage 1 becomes core objectives in stage 2. So this is why you will see a smaller list of menu sets and a higher list of core objectives. So the providers can either demonstrate 19 core objectives or 16 with 3 optional. And hopefully that makes sense. So let's quickly look at a comparison of stage 2 versus stage 1. Stage 1, let's look at CPOE, physician order entry. We said in stage 1, 30%. In stage 2, they have to do 60% of medication orders, but they also have to do 30% of lab orders and 30% of radiology orders. So now we've built up. So now that you're used to electronic ordering, now we need to build an ads to get you to fully use the EHR. And that is a very quick overview of the stages. And again, that's on the provider side. The other side of the coin is the vendors and the technology. And with that, we have a certified EHR technology. And the Office of the National Coordinator oversees the certification program. How does certification work? So certification, you have an accrediting body and you have a testing body. And so vendors must first go through testing, and if they pass the testing phase, then they would go to the accrediting body and they would actually go through certification. Once they are certified, then their product is then added to what we call a CHAPO list. And that's a certified product list. And that CHAPO list is important because once providers begin to attest and want to demonstrate meaningful use, they have to demonstrate meaningful use with a certified EHR technology. And so that list is where they would go to select the products that they are using to demonstrate meaningful use. So The provider purchases, or if it already exists, a certified EHR. You have meaningful use with a certified EHR. You successfully attest to demonstrating meaningful use, and you receive your incentive payments from CMS. And that, in a nutshell, is the process of meaningful use and of certification. And this is just a diagram to, again, illustrate how the process happens. You have an accrediting testing, and that accrediting testing, the vendor and the developer goes through. Once they pass that first stage, then they must go to the accrediting body, and then once they pass the accreditation, they are certified, they go on the list, and providers can use that technology. So in summary, ARA is the stimulus package by the Obama administration that was put in place to help the financial crisis. And under that, we have the HITECH Act. And the HITECH Act provides us the funding for the implementation of meaningful use and for certified EHR technology. Meaningful use is the concept with the intended outcome that provides a higher quality standard of patient treatment, we have the 3 stages of meaningful use, which one building upon each other. And then we have the certified EHR technology, which along with meaningful use allows providers incentive payments as well as meaningful use of EHR, which is the target of the HITECH Act. I will now take any questions.